Ever stop to think about what your brain is doing right now? Just to keep you sitting still, it's running thousands of silent calculations. And the moment you decide to move, boom, it fires off a perfectly timed sequence of commands. It's an absolute marvel. But what happens when that incredible control system starts to break down? That's what we're going to unravel today.
So, here's our roadmap. We'll start big picture, in the brain's main control room. Then we'll zoom right in on Parkinson's disease to see what's going on under the hood. After that, we'll see why it's not the only story, learn about the detective work that goes into a diagnosis, and finally, look at what the path forward looks like.
Okay, first stop, the control room. When you boil it all down, controlling movement is really about managing a constant push and pull. I mean, think about it. It's a non-stop balancing act, right? Every single thing you do, even just standing still, is the result of your brain perfectly deciding between more and less. And when that balance gets thrown off, well, that's when you get a movement disorder. And really, they fall into two big buckets. On one side, you've got hypokinetic disorders. Hypo means too little, so this is all about slowness, a lack of movement. On the other side, you've got hyperkinetic. Hyper means too much, so this is where you see extra unwanted movements like tics or tremors. It's all about that balance. So to really wrap our heads around this, let's focus on the most famous hypokinetic or too little movement disorder of them all, Parkinson's disease. Now, when you hear Parkinson's, you probably think of a tremor, right? And yeah, for about 70% of people, that's the first thing they notice. But look at this chart. For almost a third of patients, it starts with something completely different. Maybe they have trouble walking, or just feel this weird stiffness and slowness. And over time, all these symptoms start to add up, creating a really distinct appearance. You can see it in this diagram. That stooped, forward-leaning posture, the facial expression that doesn't change much, what's often called a masked face, and that short, shuffling walk. It's literally the physical result of the brain struggling to say, go. So, when a neurologist is trying to make a diagnosis, they have a kind of checklist. They're looking for what they call the classic tetrad, these 4 key signs. First, there's that slowness, which is called bradykinesia. Second is that resting tremor. You know, the one that sometimes looks like they're rolling a little pill between their fingers. Third is postural instability, which is just a fancy way of saying they have problems with balance. And finally, rigidity, or stiffness in their limbs. Okay, so that's what it looks like from the outside. But to really get it, we have to go deeper, inside the brain. And you know what? The best way to think about it is to think about a car.
This right here, this is ground zero. Take a look at the image on the left. In a healthy brain, you see that dark, rich band? That's the substantia nigra, and it is packed with dopamine-producing cells. Now look at the image on the right. In the Parkinson's brain, it's faded. It's pale. Those crucial cells have died off. This is the root of the problem.
So what does losing all that dopamine actually do? Well, this is where our car analogy comes in. It's a simple but super helpful way to think about it. Your brain has pathways that work like a gas pedal to get you going and a brake pedal to slow you down or stop. Now don't worry about all the arrows in this diagram. Just focus on the main idea. This is the gas pedal. It's called the direct pathway. Basically, dopamine from that substantia nigra we saw hits this pathway, and it effectively slams on the accelerator, sending a huge go signal to your motor cortex. And the result? You move. Simple as that.
And of course, if you have a gas pedal, you've got to have a brake. That's this guy, the indirect pathway. Again, don't get bogged down in the details. Its job is just to do the opposite of the gas pedal. It helps put a stop to movements you don't want to make, which lets you perform smooth, coordinated actions instead of being all jerky.
So what's the punchline? In Parkinson's, when you lose that dopamine, it means the gas pedal, that direct pathway, gets weak. The brain just can't push the accelerator down hard enough. And the result is exactly what we talked about. Hypokinesia. That slowness, that trouble getting started, that's the hallmark of the disease.
But here's where it gets really interesting. Just when you think you've got it figured out, the story takes a sharp turn. Because not everything that causes slowness and stiffness is actually classic Parkinson's disease.
The picture is way more complex.
And this table shows you just how tricky it can be. Look at the differences here. With classic Parkinson's, you often get that one-sided tremor, and the dopamine medication, L-Dopa, usually works pretty well at first. But then you look at something like multiple system atrophy, or MSA. The key symptom there is often something totally different, like early problems with blood pressure. And for progressive supranuclear palsy, or PSP, patients might have an unusually upright posture and sudden falls. And the biggest clue? As you can see here, for both MSA and PSP, L-Dopa just doesn't work.
So if the symptoms can look so similar, how in the world do neurologists tell them apart? Well, this is where it turns into a real-life detective story, where they're searching for very specific clues hidden deep inside the brain.
And here is clue number 1. This is amazing. In some patients with MSA, an MRI of their brainstem shows this pattern. I mean, you can see why they call it the hot cross bun sign. For a neurologist, finding this is a huge breakthrough. It points the finger straight at MSA.
And check this out. Here's another one of those telltale signs. In PSP, as part of the brain shrinks, a side view on an MRI can create a shape that looks just uncannily like a hummingbird. You can practically trace its head, its beak, and its body. Seeing this hummingbird sign is another massive clue that points the whole investigation towards PSP.
Beyond just the shape of the brain, PET scans give us another layer of evidence. They can actually measure dopamine activity, creating these amazing visual fingerprints for each disease. Just compare them. You've got the bright, buzzing activity of a normal brain, then the dimmed-down activity in a Parkinson's brain, and then a completely different pattern of loss for PSP. These are the kinds of clues that crack the case.
Okay, so once the diagnosis is made, what's next? Where are we with treatments? And what are the big questions we still need to answer?
This quote really says it all, doesn't it? It's the honest truth. Right now, we don't have a way to stop or reverse the damage to those brain cells. There is no cure. But, and this is a huge but, we do have tools and methods that can offer people a lot of relief from their symptoms and really improve their quality of life.
Today's approach is really a multi-step game plan. Step 1, especially for Parkinson's, is usually medication like L-Dopa to try and fill that empty dopamine tank back up. Step 2 might be adding other drugs to get better control over specific things, like a tremor. And for some patients, there's even a step 3, surgery, like deep brain stimulation. It's almost like a pacemaker for the brain, using tiny electrodes to help regulate those faulty circuits.
And this brings us to the final and most important question. We've seen that Parkinsonism isn't just one thing. It's a whole family of disorders, and each one leaves its own unique signature on the brain, like a hot cross bun or a hummingbird. So the real challenge now, and the real promise for the future, is to take that incredibly detailed knowledge and go beyond a one-size-fits-all approach. The question that's driving all the research forward is this one right here. How do we create a truly personalized treatment for every single brain